thesis, estimation of the anterior chamber angle parameters using ASOCT, anterior segment optical coherence tomography, and biometric parameters using optical biometry in eyes with suspected occludable angles and open angles. There are no financial disclosures or conflicts of interest. So as we all know, primary angle closure disease is a progressive disease that gradually leads to glaucomatous optic atrophy, which is an irreversible form of blindness. In fact, in the Indian subcontinent, patients presenting with acute angle closure progress to have a chronically raised IOP in 71% cases, glaucomatous optic neuropathy in 39% cases, and blindness in 15.3% cases. The dimensions of the anterior segment structures determine the likelihood of development of angle closure, and using non-invasive imaging modalities, we can assess those parameters. Early diagnosis and intervention can not only slow down the progress, but also prevent permanent optic nerve damage. So the rationale behind the study was as follows. Many cases are undetected. Gonioscopy, although is the gold standard, but has an inherent subjectivity to it, is a time-consuming and often avoided procedure. So this calls for a need for non-contact procedures like anterior segment OCT and optical biometry, which can objectively evaluate the angle parameters, make us understand those parameters, and can be compared. And the lacuna in this topic is that there is paucity of data comparing the angle parameters and biometric parameters between the two groups that we mentioned. So the primary objective was to compare the anterior chamber angle parameters that were measured by ASOCT in suspected occludable angles and open angles, and the second one was to compare the biometric parameters using optical biometry between the two groups. The secondary objective was to find the level of agreement in the calculation of eye to white and CCT by ASOCT and optical biometry. So the study participants were basically patients aged from 20 to 60 years with Van Herrick grades of 0, 1 and 2, without any ocular pathology, cataractus changes, or anything that could affect the angle parameters. So these were the suspected occludable angles, the group 1, and group 2 were open angles with Van Herrick grade 3 and 4. This is how we calculated the sample size, and the minimum sample size in each group was supposed to be 30 eyes. So the design was an analytical cross-sectional study performed at a department, and the study recruitment was for 1 year. 128 eyes of 64 patients were recruited, and group 1 had 68 eyes and group 2 were open eyes. All the patients who were presenting to the OPD underwent a Van Herrick examination and were grouped, and they underwent ASOCT and optical biometry, and the outcome variables were established. So Van Herrick grading, as we all know, this is how it was performed. So this is the ASOCT measuring the CCT and the angle parameters using the tools. We had used a Heidelberg Spectralis machine with the ASM module, and all of the locating the scleral spur was the most important, which was done, and all the parameters that are listed here were calculated for both nasal and temporal. And lens vault and white to white was also calculated. Similarly, IOL master was performed following this, and these are the list of the 5 parameters that we assessed and documented and compared. So these are the outcome variables that we got, 6 parameters on ASOCT and these many on IOL master. Means were computed and compared, and the results, age and gender, I won't go into. Most of the data that we got was normally distributed, and following this testing, we established that all the parameters that we measured were significantly different between both the groups for both ASOCT, and the biometric data was also significantly different. I'll skip these 2 slides. So our results, there were smaller parameters in suspected occludable angles with a higher lens vault, and optical parameters were smaller in the suspected occludable with a higher lens thickness. Previous literature has not compared these 2 groups, and the Spectralis machine ASOCT device has only been used thrice in 3 studies according to the literature that we had searched. Limitations includes that the sample size was smaller, the limited duration for recruitment, and this was not a prospective study but a cross-sectional study. So we further recommend for prospective and multicentric studies, which can be performed to assess the ability of ASOCT and optical biometer to detect progression of the angle closure and validate these findings. So to conclude, ASOCT can be used for assessment of the angle parameters, and we can further understand and make kind of a cutoff value that can further establish us whether we can, how to further proceed. Sorry, I crossed my timing.
Did you do a gonio in all these patients?
Yes, sir. Yes, sir.
All of them?
All of them, sir. And that it was occludable, then we had went ahead with LPI, with laser peripheral iridotomy. But all of these measurements were done before we performed a gonioscopy.
And in your study, you do all the cases gonioscopy?
Yes, sir. We did for this. So the standard of management is for shallow AC was that. So we did perform. And even for open angles, since it was
No,
a...
you means the occludable angle, la?
Yes, sir.
Occludable angle is best seen by gonioscopy or your ASOCT?
So both were done. Initially, we performed the ASOCT parameters because it's a contact procedure. Gonioscopy is a contact procedure. So we did not want anything that could compromise those micromillimeter, those values. So that was done first, and then we...
Even if you do compress the cornea, sometimes the angle become open.
Yes, yes, doctor.
That is the advantage for the gonioscopy. The glaucoma specialist must be known the gonioscopy, otherwise
I
difficult.
used a Sussman 4-mirror gonioscopy for all the patients.
No, I have a clarification. Like you have classified the groups based on Van Herrick's
Van
grading.
yes, sir.
So how can you actually say that group 1 is occludable only based on Van Herrick's grading?
I agree with that, sir, but this...
Because Van Herrick's 2 can be an open angle on gonioscopy. So without doing a gonioscopy, you cannot actually say like these parameters are good based on a Van Herrick's classification, because Van Herrick's is not a gold standard to diagnose an occludable
Yes,
angle.
sir. So there was a similar study that I had quoted here. They had actually
They assessed all three.
compared. Yes, sir, all
They
three.
included
Yes, sir.
gonioscopy also.
So the idea behind this was there is a study that has quoted that the gonioscopy is very less performed. They have actually compared the percent. So my idea was that clinically it's much easier to do a Van Herrick grading that is very commonly performed. So what if we can just look at that, see which are the suspected, do that grading and just send them off for an ASOCT. That is, although
still it
I'm
will-
not denying the
No, but
importance
still it
of
will come under
gonioscopy here.
suspect only. No, you cannot actually
Yes.
diagnose it as occludable.
Further, we can, so that was the idea. If there is no study actually has compared these, based upon these Van Herrick findings, two groups have not been compared. So I wanted to find that out. If there is difference, significant difference, statistically significant difference between these two values, which was there.
Or else you
So-
could have done one thing. You have done gonio in all these cases after ASOCT. You should have put that and compared. At least those results should have been provided, like whether those ASOCT parameters are matching with the gonioscopy
Could have
findings.
included, yes, sir. Yes, I agree with that, sir.
Okay, with this, we have come to the end of this session. I request all the judges and chairmen to kindly receive the certificates. So first, Dr. Vinid Ratra. Anyone to take a